Arthritis following instability in the athlete's shoulder. X-ray evidence of osteoarthritis following a primary traumatic anterior shoulder dislocation is in fact fairly common. Avelius undertook a study in Sweden in 1979 where they looked at 257 patients who'd undergone a first-time anterior dislocation. They did a number of studies following this up, but recently reproduced a 25-year follow-up. What they found was that recurrences increased for up to 10 years but then stabilised. They also found that over 50% of patients under the age of 25 at the time of their first dislocation required surgical stabilisation. Very interestingly, at their 25-year follow-up, they found that 66% of patients had developed radiological evidence of arthropathy, and that 34% of these were moderate to severe. There are some poor prognostic indicators that suggest at the time of dislocation a patient may develop osteoarthritis. Firstly, the presence of pre-existing osteoarthritis before stabilisation, multiple dislocations, and some types of surgery can predispose patients developing a subsequent osteoarthritis. Non-anatomical stabilisations, such as a putty plate procedure, tend to strengthen the anterior capsule, but then push the head backwards, developing point loading of the humeral head onto the posterior glenoid. This can lead to the development of a biconcave glenoid and accelerated osteoarthritis. The presence of metalwork around the glenoid will obviously lead to significant trauma to the articular surfaces. This is particularly the case when screws are inserted, such as a latter procedure. In this example, we have a patient that's had 2 screws and a plate put in 2 laterally, and as a result has developed accelerated osteoarthritis due to damage of the humeral head. Management of osteoarthritis following instability really involves managing the symptoms, so they're non-operative and operative treatments. On the non-operative side, some patients do feel that nutritional supplements, including glucosamine and chondroitin, can help with their symptoms. On the therapeutic side, non-steroidal anti-inflammatory tablets, corticosteroid injections, or viscosupplementation in the form of hyaluronic acid can actually help with symptoms and allow athletes to get back to a fairly high level of play despite the presence of fairly marked osteoarthritic change. If or when non-operative measures fail, then there are some operative options available, and these really depend on the lesion. The smallest lesion is a focal chondral lesion, such as a glenoid labral articular deficit. This is often found at the time of instability surgery and can be treated with microfracture and bringing the capsule more posteriorly to cover the defect. Full thickness chondral lesions on the humeral side, which are relatively rare, can be treated either by microfracture or by chondrocyte implantation. Contained osteochondral lesions, which tend to be on the humeral side but are pretty rare, can be treated with an osteochondral allograft or with a partial resurfacing arthroplasty. Uncontained osteochondral lesions, which are normally represented by bone loss at the anterior inferior glenoid, can be treated with a bone block procedure, so either an Eden-Hibonnet or a Latarjet, or on the humeral side where there can be a very large Hill-Sachs lesion where an osteochondral bone block can be used. Global degenerative change can be very challenging. Operative intervention ranges from arthroscopy and debridement ultimately to an arthroplasty. A simple arthroscopic debridement, removing any flaps of articular cartilage and loose tissue, can give some symptomatic relief. A more extensive arthroscopic option is a complete arthroscopic management procedure. This was described by Pete Millett's team. This involves removing loose bodies, a humeral osteoplasty where the inferior goat's beard osteophyte can be excised, a circumferential capsule release, neurolysis of the axillary nerve, plus or minus a biceps tenodesis. In my experience, this can often give good results for 2 to 3 years, but really is a staging procedure. For patients that have developed a post-capsular osteoarthritis due to a non-anatomical stabilisation procedure and so have developed a biconcave glenoid, a chondroplasty may be an option. This can be undertaken as an open or an arthroscopic procedure and essentially involves burrowing down the central part of the glenoid by about 3 mm to try and recreate its concavity. When this is done as an open procedure, there's also the option of undertaking a subscapularis lengthening to try and rebalance the joint. If following optimal non-operative and arthroscopic operative treatments, a patient continues to have significant symptoms, the only further option would be to consider an arthroplasty. Often these patients are relatively young, and I certainly prefer, and most others prefer, to use a short-stemmed implant with a ceramic head. My current implant of choice is an affinis short stem, which does have a ceramic head and a pegged glenoid. This is an example of a patient in their mid-40s who'd previously undergone an open putty plate procedure and a subsequent open rotator cuff repair, who's developed post-capsular arthritis with a biconcave glenoid. Following a short stem arthroplasty with a ceramic head, the shoulder's been rebalanced and they gained very good symptomatic relief, both with regards to pain, function, range of motions. They're able to return to swimming and most sporting activities apart from contact sport. In summary, following a first-time traumatic anterior dislocation under the age of 25, there's a 66% chance that by the age of 40 there will be radiographic evidence of osteoarthritis. However, this may not necessarily be symptomatic, and you only need to treat patients with symptoms. Treatment should obviously start non-operatively, progressing to operative intervention as required. Following a first-time traumatic anterior dislocation, measures to delay the progression of symptomatic osteoarthritis would be avoiding becoming a recurrent dislocator, so considering stabilising the shoulder. And when undertaking this stabilisation, it's important to undertake an anatomical repair and avoid metalwork. In this particular example, a revision has been undertaken. The patient had originally had a lache, but the screws have broken. But the inhibit has been fixed using suture buttons, so that should this patient require surgery down the line, there's one less bit of metalwork to remove. If you've enjoyed this talk and would like to know more about instability and osteoarthritis and any other conditions involving the shoulder, you may wish to visit my website cambridgeshoulder.co.uk or my YouTube channel Cambridge Shoulder, which has over 50 videos of various talks and procedures around the shoulder.